Good morning slash afternoon, everyone. Dr. Witcraft and I are excited to talk a little bit about perinatal substance use with you all. Before we get started, and if you want to next go to the next slide, Rachel, we wanted to let you all know about an exciting opportunity that we are hosting at MUSC and partnering with some of our colleagues at Prisma to hold a maternal healthcare conference. So this conference is going to cover topics that we talk about today, but also other perinatal mood and anxiety and substance use disorders. So the conference is virtual. It's going to be on April 5th, and we're going to have some expert speakers and community panel members discuss perinatal mood and anxiety disorders, substance use disorders, different treatment and practice considerations, and evolving systems of care. So if you're interested in this event, we would love to have you. You can register online through the MUSC psychiatry website. We are offering CMEs or CEUs if those are helpful for you. And you can always email psychevents@musc.edu or reach out to either myself, Dr. Gale, and we're happy to disseminate the link so that you can register for the conference. So today I will be talking and really just scratching the surface on cannabis use during pregnancy and postpartum, including reviewing some of the outcomes that have been associated with use, talking about practice guidelines and some clinical recommendations and future directions. And then Dr. Witcraft is going to lead us through a practice challenge, treatment retention for perinatal opioid use disorder. So just as a brief background, marijuana or cannabis is composed of the leaves and flowers of the hemp plant. The potency varies based on the location of origin of the plant, the cultivation method, and method of storage. The active ingredient is called THC, and this is present in all parts of the plant. However, the most concentrated and the strongest marijuana comes from the resin that's in the flowering tops of the female plants. The plant itself contains over 400 different chemicals, including about 60 compounds that are chemically related to THC, and those are known as endocannabinoids. Cannabis or marijuana is the most commonly used substance in the United States. And the way that it works in terms of a recreational or active use is through THC, which acts on the endocannabinoid system. And so this system is involved in a whole different variety of processes, including pain management, memory, mood, appetite, stress, sleep, metabolism, immune function, and reproductive function. And the psychoactive component or psychoactive metabolite of cannabis is delta 9 THC. And this acts on cannabinoid receptors within the central nervous system and some of those peripheral locations. And while the THC and marijuana are not recognized by the federal government as legal, it's been legalized for medicinal or recreational purposes in 38 states, with even more of them legalizing CBD or THC oil, which can create some challenges, I think, for healthcare providers when they're talking about cannabis use with patients. So this is just a little graphic to represent some of the current statuses in terms of legalization. The light green states depict areas in which medicinal marijuana has been legalized, but not recreational. The darker green states have both medicinal and recreational legalization or decriminalization. And then the white states depict states that do not have either. But some of these states actually might have legalized CBD or THC oils. South Carolina is not one of those states. So we do see sex and gender differences in the ways in which cannabis is used. And so gender differences are seen in motivators of use. So especially in regards to the role of stress. Female cannabis users expect stress reduction as a result of their use and primarily report using cannabis as a coping strategy for stress, whereas men are more likely to report using cannabis for enhancement of positive affect. And despite men having an overall higher lifetime risk of substance use disorder, including cannabis use disorder, women have a faster progression from use to disorder. They have more severe withdrawal symptoms, higher risks of relapse, higher levels of co-occurring anxiety during active use and withdrawal, and overall poor responses to treatment. So rates of cannabis use in the general population continue to rise, and rates of cannabis use in pregnancy are increasing at similar rates as the general population. So about 18% or 1 in 6 pregnant people report using cannabis. And there's a lot of confusion about the risks versus benefits to cannabis use during pregnancy and in the postpartum period. So this data is a little bit old, but from the National Surveys of Drug Use from 2005 to 2012, folks reported that women, or rather pregnant women specifically, reported no risk of harm, rose from about 26% in 2005 to 65% in 2012. And notably, 2012 was before many states had legalized either recreationally or medicinally marijuana, which actually may have compounded the confusion since then. So, some of the perceived benefits that folks report in pregnancy are for management of pregnancy related symptoms like nausea, pain, or sleep disruptions. And actually, providers in one study, at least one study, have been found to be recommending its use to perinatal patients. In fact, cannabis use during pregnancy and postpartum is associated with a number of negative outcomes for both the mother and the child. Importantly, THC does cross through the placenta and enters the fetus at about 10% of maternal levels. And if you recall when we talked earlier, THC acts on endocannabinoid receptors. And these receptors are concentrated in different parts of the brain during fetal development as compared to in an adult's body. So the maternal risks of marijuana use are related in part to method of ingestion, some of the risk-taking behaviors that are seen while intoxicated on marijuana, polysubstance use that is often co-occurring, and the mental health complications, including exacerbation of existing mental health symptoms. Multiple studies have shown an association between cannabis use and depression, anxiety, and other psychiatric conditions, including psychosis. It's not uncommon for people to report using cannabis to help manage some of these symptoms, when in fact we know that use really can exacerbate those symptoms.
Hey Marie, for some reason, I'm not sure if other people are noticing, but I think something's happened to your volume all of a sudden. I don't know. There we go.
Can
Thanks.
you hear me now?
Yep,
Perfect.
we can. Perfect. Thank you.
Sorry about that. I'll start over. Did you all hear the last slide? Do you want me to start over with this one?
You can start with
Actually-
this one, yeah.
Okay. So the maternal risks of marijuana are mostly related to a few different factors. So the method of ingestion, some of the risk-taking behaviors that we see when folks are intoxicated on cannabis, a lot of the polysubstance use that can be associated, even just like alcohol or tobacco use, and some of the mental health complications, including exacerbating existing mental health symptoms. So a number of studies, this is pretty well established, have shown an association between cannabis use and depression, anxiety, and other conditions. And a lot of people actually report using cannabis in almost a medicinal way to help manage some of those symptoms, when in fact, we know that use really can exacerbate their symptoms, both in the short term, but especially in the long term. There's also notably a theoretical risk of impact to implantation when folks are trying to conceive because of the involvement in endocannabinoid receptors in the reproductive system. So overall, it's challenging to study some of the birth outcomes and outcomes related to perinatal cannabis use. Of course, some of this is because of ethical considerations. We can't randomize folks to use during pregnancy or the postpartum period and track those results. But there are a number of other reasons. So we don't have a lot of studies that have really explored the impacts. And some of the older studies might not actually be representative of the current outcomes that we have. And that's because of some of the changes to potency of marijuana that we've seen over the last 20 and 30 years, and is actually even increasing since legalization has become more widespread. It's also really hard to quantify like the amount of drug used, taking into consideration the potency of the THC while used, and measuring some of those factors that we know are associated with use and some of the negative birth outcomes, like family factors, SES, tobacco use, and some of the mental health factors. However, we do have some data, and especially more recently, we have some really good data that's starting to come out. So, one of the more recent retrospective cohort analyses that have controlled for many of those co-founders that affected some of the earlier studies showed that newborns who were exposed to marijuana had higher rates of low birth weight, preterm delivery, NICU admission, and lower APGAR scores compared with matched newborns who were not exposed to cannabis. There's also pretty well established evidence to support evidence of neurodevelopment problems as a result of cannabis exposure during that prenatal period. So these deficits include visual problem solving, visual motor coordination, visual analysis, decreased attention span, and some other behavioral changes, which have been found to continue into young adulthood. And I will say, we don't know if the changes can continue beyond young adulthood yet, because those folks haven't been old enough to study. So as far as we've been tracking them, they have been showing some of those changes. One study found greater risks of autism and learning and intellectual disabilities in offspring who were exposed to marijuana during that perinatal period. There's some data too to show that newborns with that in utero exposure to THC can undergo a neonatal abstinence-like syndrome, which is characterized by tremors, increased startle reflex, and a reduced habituation to light. So a lot of folks have a misconception that once you're not pregnant anymore, you're in the clear in terms of cannabis use for some of those negative outcomes. And that might account for some of the high rates of relapse that we see. So for women who used cannabis regularly prior to pregnancy, stopped use during pregnancy, about 79% were found to relapse within the first 4.5 months postpartum, which is a really significantly high number. Data suggests that reasons include returning to use for stress management as a sleep aid, and even management of some of that pain associated with childbirth. And one study found even higher numbers, so 84% reported that they were using cannabis for stress and anxiety relief in the postpartum period. So as I mentioned, these are considered or oftentimes perceived as safe cannabis use in this period, but use has been associated with negative outcomes, again, for both the parent and the offspring. So we'll talk about lactation specifically first. Endocannabinoids are lipophilic, so they cross the blood-brain barrier. And unlike a lot of other drugs and medications, THC is excreted and it's also concentrated in breast milk. So breast milk can have up to 8 times the THC concentration as maternal plasma levels, and actually can be detected in breast milk for up to 6 days after use. So this is in part because of the long half-life, but it's more difficult to quote unquote pump and dump than it would be for other substances like alcohol. And I think a lot of people might not realize that. It's also well established that cannabis exposure in that underdeveloped brain, so the childhood and adolescence brain, is associated with some of those changes that we talked about earlier in brain function and cognitive functioning, like memory and attentional changes. So exposure during lactation or even secondhand exposure can have similar effects to a growing child's brain. And you might be thinking, what if a parent is not chest or breastfeeding? There are still concerns related to mental health outcomes for moms who are not using cannabis, who are using cannabis when they're not breastfeeding. So if they're formula feeding. We know postpartum anxiety and depression have impacts to mom and child. And if many parents are reporting using cannabis to help manage some of those symptoms, especially the stress and anxiety symptoms. We have to wonder, how is that actually having an impact on them and their offspring? And we could likely predict that the same behavioral or emotional outcomes would be present in children whose mothers are using cannabis, even if they're formulating. So as a result, some of the big guideline and associations have really released some practice guidelines and recommendations. So this is just like a very big picture. Unsurprisingly, ACOG, American Academy of Pediatrics, and the FDA all recommend against cannabis use in pregnancy and postpartum, specifically during breastfeeding. The FDA goes a step further and strongly advises the use of CBD in any form during pregnancy and while breastfeeding. CBD is the oil that's extracted. It's not supposed to have the active ingredients in it of THC, but that's a pretty unregulated market. So there's not a lot. We really don't know a lot about it, and it really hasn't been studied as much. So it's recommended just to avoid that. We do know, though, that higher doses of CBD that were given to pregnant animals in studies suggest that there were abnormalities that were seen in the reproductive system of the developing male fetuses, including decreased testicular size, low testosterone, and sperm abnormalities. So we are seeing some of that as a result of CBD use in animal studies. So some practice recommendations to all of you that are working with pregnant and postpartum women. A shared decision-making approach is strongly recommended when exploring and talking about cannabis use during pregnancy and the postpartum period. Some data may support a harm reduction approach is better than continuing to use at the same levels. So for example, reducing use, frequency, or quantity when using, not breastfeeding within 1 week of use, some of those harm reduction strategies. Because of the high rates of co-occurring psychiatric conditions and symptoms and other substance use, it's really important to fully assess patients who might be reporting the use of cannabis in your practice. And I would say vice versa. If you have patients who are reporting high levels of anxiety or some other substance use, I would also assess for cannabis use. The reason being, there are some effective evidence-based treatments, both medication and behavioral, for things like anxiety, depression, stress, sleep disruptions, and substance use, even in the perinatal and postpartum periods. So helping your patients to understand their options to managing the symptoms they might be experiencing in ways that don't increase the risk of harm to themselves and their child can be really helpful. Another thing just to be aware of, if you're practicing and working with people who use cannabis in the perinatal period, is something called cannabinoid hyperemesis syndrome, or CHS. So CHS is characterized by a history of chronic marijuana use and acute onset nausea, vomiting, and abdominal pain. Symptoms are alleviated by hot showers, and episodes can last 24 to 48 hours. So it can be challenging to differentiate hyperemesis related to pregnancy from that cannabinoid hyperemesis syndrome. So CHS should always be considered in patients who are presenting with some of these symptoms with a history of chronic marijuana use, atypical presentation of their symptoms, and failure to respond with the usual course of treatment that you might use for pregnancy and vomiting and nausea and vomiting in pregnancy. Resolution of CHS just requires stop using marijuana. So if we're looking toward future directions, unfortunately, most of the studies that we talked about today are cross-sectional, and temporal relationships between things like stress, anxiety, mood, sleep, and cannabis use have really not been explored. Current research by some of our MUSC faculty, Dr. Kill and Dr. Brady, are starting to prospectively and quantitatively examine these relationships in a large cohort of women. We need future work, though, to understand any differences in safety perceptions or use in states with legalization versus without. Understand how we can support providers in all different states to be able to talk about and feel comfortable talking about this with patients. An example that I like to use is just because alcohol and tobacco are legal does not mean that they're safe to be using during pregnancy, and we can apply a similar framework to cannabis. Studies can also be designed to explore different interventions to support women in the postpartum period to manage their symptoms that are driving cannabis use. Um, we have like well-established treatments, medication treatments, behavioral treatments, CBTI, ACT, regular CBT to help with anxiety, depression, pain management, all of these things. And some of them have been validated with the perinatal population, some have not. But I think that we need to be investing a little bit more to help support women during this phase so that they're not doing harm to themselves and their children. We also, it's going to be helpful to understand how do these interventions function with this population and how might we have to modify them so they're accessible and they're still effective. And then lastly, I think we need to increase education, not only to birthing people, but their providers to help facilitate that shared decision-making approach and really increase the comfort in talking about peripartum cannabis use so that we can really help support our patients.